All right, I think we should get started. Is that okay? That we get started? Because I have a lot of stuff to go over. And I'm going to be discussing some of our research in AFib. Some of you guys may be familiar with it, with some of it. Some of it is brewing, a lot of it is very preliminary, but I hope to get your comments. A few things about just general AFib and why we are interested in it and why we have the research that we do is because we don't understand it. We tell patients this paradigm of focal activity coming from the pulmonary veins, and that as its electricity spreads from the veins, it becomes disorganized, and therefore the atria are irregular, and then the ventricles follow the best they can. And that works well, and this is based on seminal work by Michel Hassaguer in 1998, where he showed that the first beat that started AFib, so if you were to map AFib, and you cannot map AFib, but you can map the first beat because it's a single PAC. Well, he noted that most of the first beats initiating AFib came from the pulmonary veins, and that if he ablated the areas that triggered those first beats, we actually had success better than any drug reported to date, with 68% of the patients cured. So this led to a revolution of AFib management, which is where we are now, where pulmonary vein isolation has become the standard of care for rhythm control, for invasive rhythm control. Yes?
What are the cells adjacent to the pulmonary veins that are responsible for this activity? What do they look like? What's their morphology, function?
These are regular myocytes. There's been reports of sinus node-like cells, but that's not really accepted as the prevailing, the mechanistic paradigm. These are regular myocytes that have a leaky ryanodine receptor, so the sarcoplasmic reticulum tends to leak calcium in diastole, and that leads to delayed after depolarization. So that calcium, that intracellular calcium, during diastole, the myocytes, through the sodium-calcium exchanger, they take one calcium out and they they exchange that for 3 sodiums in. So that's one positive charge in, and that depolarizes the membrane, and it triggers a PAC. And now, why a PAC from the pulmonary veins leads to AFib and other PACs don't, I'll explain that in a second. But the bottom line, as an introduction, the pulmonary vein ectopy paradigm has served to create a therapy which is better than anything we had before, but it's far from perfect. So for paroxysmal AFib, if you compare drugs versus AFib, pulmonary vein isolation, success is about 70%. If you use contact force to guide your procedure, you get up to 81%. If you use laser, it's in the range of success rate, whether you use cryo, laser, contact-guided radiofrequency ablation, or standard ablation, is anywhere between 75 to 80% for paroxysmal AFib. If you look at persistent AFib, it's a lot worse. Single procedure success can be as bad as 31% or 30%. Most of our experts recommend in guidelines to do more extensive ablations when you are ablating persistent atrial fibrillation. Remember, we thought, okay, the paradigm that I explained to you about AFib is, okay, paroxysmal AFib starts with an extra beat coming from the pulmonary veins. If you've been in AFib for 5 years, who cares about the first beat that initiated it? It's been 10 years going on, so that mechanistic paradigm cannot apply to persistent AFib. And what people have done is basically expand the lesion sets or do bigger lesion sets to isolate the pulmonary veins. So these spheres are the volume of the left atrium, looking at it from different perspectives. These are the lesion sets, a single circular lesion set done to isolate the right-sided pulmonary veins, a single circular lesion set done to isolate the right-sided veins. And people have compared that alone or combined with other lesions along the mitral valve, along the septum, or where areas of rapid electrical activity like this are detected. So if you compare pulmonary vein isolation alone versus pulmonary vein isolation with all these things, it's no better. It's the freedom from atrial arrhythmias after a single procedure is very similar whether you use pulmonary vein isolation alone or combined with other things. This was also studied in another larger clinical trial published in the New England Journal 2 years ago, comparing pulmonary vein isolation alone, like this schematic, versus combined with ablation of complex electrograms. And this is very subjective, what you think is complex, what you see rapid electrical activity. It's up to the operator's judgment, but areas where you saw those potentials were ablated on top of the pulmonary vein isolation. And in another group, they looked at different lines, so a roof line and a mitral annular line. The results showed that basically it's the same. We are stuck with a success rate in the 60s, 50s after more than one procedure for persistent AFib, in part because we don't understand it. Other people are trying to add more ablations, and this is the latest clinical trial published 4 months ago in persistent AFib, looking at the extensive pulmonary vein isolation combined with isolation of the left atrial appendage. That seems to be doing a better job, but it's just a reflection of ablating more and more and more. There's less tissue to fibrillate, with the potential problem of stasis in the appendage even when you're in normal rhythm. So our approach has been to try to step back and go back to the mechanisms and see if we can understand AFib. And multiple mechanisms have been proposed. I mentioned the ectopy from the pulmonary veins. There's a lot of interest into the effects of the innervation of the left atrium. So the left atrium is coated with a very dense layer of nerves. Parasympathetic ganglia are present there, and also you get post-ganglionic sympathetic fibers. There's also sensory neurons. Nobody knows exactly what they do. These are the ligament of Marshall, which I will explain a little bit more later, is also full of nerves that communicate with the atrium and have impact on the physiology of the atrium. The bottom line is that we don't know. When people have tried to map atrial fibrillation with fluorescent techniques, this is using a fluorescent dye that makes the cell fluoresce proportionally to their voltage. So when the cell is depolarized, it becomes bright. And you can actually put a camera and record the activation. So mapping the left atrium in the same tissue, you can see episodes of reentry here, going around this area, episodes of focal activation arising from there. And if you look long enough, you get enough patterns to get confused and not understand exactly what's going on. A leading group in Michigan came up with the idea of the mother rotor. So the idea of this group is that AFib is maintained by a stable reentrant source, shown here, and from which waves emanate and they propagate in an irregular fashion through the rest of the tissue. So you have a spot that is undergoing functional reentry, the mother rotor area, and that can beat as fast as 6 hertz, 8 hertz, so super fast, cycle lengths of 150 milliseconds. And from that spot, waves propagate. Now they encounter pectinate muscles, and the waves do not propagate with one-to-one conduction, but rather Wenke back, so that's why you get the irregularity. And in different experimental models, you can reproduce that. And this is atrial tissue exposed to carbachol, that is a cholinergic agonist, to isoproterenol, it's a beta agonist, and ryanodine, and you get a stable rotor. When you don't have ryanodine, the rotors tend to be unstable. So you get them, and then they go away. In persistent AFib models, you tend to have a stable rotor. In this case, kind of meandering, but located in the left atrial appendage. In this is a sheep model. So, going back to what makes this happen? What are the physiological conditions that make the atrium fibrillate? And one area that has received a lot of interest is the autonomic cardiac nerve. So as I described, the atria are covered by nerves, and these nerves have several populations of neurons. The most common are the postganglionic parasympathetic neurons. So you get nerves from the vagus that make synapses with postganglionic parasympathetic neurons that then release acetylcholine. Acetylcholine actually opens up a potassium channel, shortens the action potential duration, and hyperpolarizes the cells. That's why in the AV node you get AV block when you get acetylcholine, or when you give adenosine, which acts in the same channel. But there are also postganglionic from the stellate ganglion and sympathetic nerves, postganglionic fibers that actually provide connections, retrograde connections to these neurons and inhibit them. Most interestingly, at least for me, they're sensory neurons. The sensory neurons, nobody knows exactly what they're for. We know that when taken out of tissue and exposed to different agonists, we know that sensory neurons respond to their chemoreceptors, they respond to low pH, they respond to hypoxia, and that they respond, they're mechanoreceptors as well, and that these sensory neurons work activating the postganglionic neurons. That's all in vitro knowledge, but nobody knows exactly how they work in vivo and what role they could play in AFib. What we know is in animal models of paroxysmal AFib, when a dog that is paced intermittently every day for several hours, but intermittently, the dog will go on to develop paroxysmal AFib during the times he's not getting paced. And in that, this happens for a few weeks. And in that situation, when you record, if you are able to record the sympathetic, the stellate ganglion nerve activity and the vagal nerve activity, it's fascinating in that preceding the atrial fibrillation, you get simultaneous vagal and sympathetic activations. And how does this lead to atrial fibrillation? It's also fascinating from the cellular standpoint. So this is what is known. When a myocyte gets exposed to acetylcholine, this opens potassium channels that shorten the action potential. Basically, potassium comes out, you go from a long action potential to a shorter action potential. That's great. That basically allows the cells to beat faster because it shortens the refractory period. If on top of that you add catecholamines increase the calcium transient. So every systole, the calcium that is leaked, the calcium that is released and that makes the contraction is more than in control. When you have both, you end up having a situation where you have a short action potential duration combined with a large calcium transient. So you see this overlapping period where you have a lot of calcium in the cell when electrically it's already going into diastole. So like I explained, sodium-calcium exchange, and this takes this calcium and pumps it out in exchange for sodium, that depolarizes the membrane, and that leads to early after depolarizations. And that has been shown in experimental models. So we have an idea as to why this neuromodulation can create the trigger of AFib by creating this early after depolarization, and also can create the substrate of AFib, because if it shortens the action potential around across the atrium is able to sustain much faster rates than during physiological conditions. Okay, so it's also known when you measure electrical activity, not only of the vagus and the stellate ganglion, but also the ganglia inside the cell, inside the heart, sorry. The ganglia that are coating the left atrium, there are releases before the onset of atrial fibrillation. So I'm going to skip a few of these slides to take you to what we have been doing to test this neuromodulation hypothesis of AFib. So as I mentioned, the plexi of nerves in the left atrium contain sensory neurons, and the sensory neurons have their somas in the ganglia, but also in the nodose ganglion, intrathoracic ganglion, the dorsal root ganglia. So they communicate up with with integrating centers of the central nervous system, and they're mechanosensitive, chemosensitive, release substance P, and the chief receptor that mediates their activation is this TRPV1. So, okay, TRPV1 is ubiquitous in sensory neurons. It responds to heat, to touch, and to other things, and is what we have in our tongue when we eat something spicy. So TRPV1 gets activated by spicy stuff. There's a pharmacist called Scoville that came up with a Scoville heat scale that basically measures in some units, I don't know where the units are coming from, how spicy food is, and this is related to how potent an analog of TRPV1 the food you're eating has. So capsaicin is very active. But looking into this, and this I came across this by chance, I came up this compound, resiniferotoxin. If you look at capsaicin, it has, I don't know if you can read this, but like 16 million Scoville units as to how spicy it is. And then you go down and then you get habanero peppers, jalapenos, and others. Resiniferotoxin is 16 billion units. It's so potent that it binds to TRPV1, which is a non-selective cation channel, particularly sensitive to calcium. It opens it and leaves it open. The neurons get maximally activated, and then they die. They die of calcium toxicity. So this was interesting to me, and I thought, okay, this could be a very, very effective way to test what sensory neurons in the heart do. And being a clinician, I do a lot of epicardial ablations and get into the epicardium. So we thought, okay, we have this compound that activates sensory neurons. And I also thought, okay, a clinical situation that we know is associated with AFib is sleep apnea. Okay? It's known sleep apnea is part of the management of sleep apnea is part of the management of pre-ablation and post-ablation patients. We know that if patients have sleep apnea and they're not compliant with their CPAP, they're not going to respond to the ablation. And we know what happens during sleep apnea when you stop breathing. You go hypoxic, your pH drops, CO2 goes up. What else do I want? Low pH, high CO2. We know that sensory neurons respond to that. So it's a great test, great clinical scenario where makes sense to hypothesize that sensory neurons would play a role. And the sensory neurons are mostly in the left atrium, so I thought, wouldn't it be nice to have some neurons in the left atrium checking how well oxygenated blood comes from the lungs when you breathe, and to respond to that immediately? So, okay, I thought, let me put this into an animal protocol that could test this. So we bought the resiniferotoxin, which was surprisingly easy to buy. It grows in a cactus in Morocco. And we took dogs. We measured a baseline refractory period. We created a map of the left atrium. So this is the left atrium of the dog, and we measured refractory period in 3 spots. And then we induced apnea, and we measured again refractory period during apnea. Then we go back to a normal state, an eupneic state. Then I had access to the pericardium. I had a sheath in the pericardium using the technique we do for epicardial ablations. Then I injected resiniferotoxin into the pericardium, waited, and then measured refractory periods again, and induced apnea again, and measured the refractory period to see if I activate these sensory neurons and kill them, if I ablate the sensory neurons in the epicardium, and the sensory neurons play a role in the response to apnea, I should eliminate the response to apnea, right? Makes sense. So let's see step by step. So we measure refractory period at baseline. It's variable, but it's around 110 milliseconds. So these are electrical recordings from the left atrium in the dog. We're pacing S1, S2, and we capture. Then we induce apnea, and we see that, so at baseline, during normal respiration, the ERP in this dog was 90 milliseconds. In this dog, during apnea, with 80, we could not only capture, whereas before we couldn't, so the refractory period has shortened, but with a single extra beat, we induce AFib. In all the dogs we tested 10. So on average, the refractory period dropped during apnea, and all the dogs could have AFib induced with a single extra during apnea. Then we give the RTX, the resiniferotoxin. And the first thing we did this, I left the fellow doing it. I got access in the pericardium, went up to do a case, and then the veterinarian is calling me. They want to cancel the protocol. The dog doubled his blood pressure. So the dog went from a blood pressure systolic in the hundreds to 230. The dog was shaking. This is the dog under general anesthesia. And the dog under general, you can cut the chest, you can cut the sternum, and it doesn't move. The dog was shaking. Blood pressure was 230. The heart rate went up, but not that much. Not only that, 10 minutes into the RTX, we get this ST elevation. 3 out of 10 dogs went into ventricular fibrillation. We shocked them. We got them back. We lost one. And then 20 minutes later, we're back to our baseline situation with a normal EKG, and everything is fine. Then we go and induce apnea. We try to induce apnea. And after RTX, the ERP not only did not shorten during apnea, but actually prolonged during apnea. And we no longer could induce AFib. So if you summarize the data, when we normalize the ERP to 100% of the baseline, pre-drug apnea dropped the refractory period by about 30%. Post-RTX, apnea increased the refractory period. And we could no longer induce AFib with a single extra. So at least we could show that the sensory neurons that we ablated with RTX played a role in the apneic, the response, the electrophysiological response to apnea and the susceptibility to AFib induced by apnea. It also changed the way the blood pressure responds to apnea. And we did long apneas because we only have 100% FiO2, so the dog is ventilated with 100% FiO2. The PO2 is in the 400s. To get the dog to desaturate, it takes a long time of apnea. So 6 minutes. One of the reviewers said this was cardiac respiratory arrest, not apnea. But the bottom line is that the RTX abolished the increased blood pressure and the heart rate changes that occurred during apnea. We tried to get this published, and it got rejected in 3 journals. And some of them had the reviewers had absurd comments, but I knew a big weakness was this is a very much translational, a phenomenological study, not a mechanistic one. I think that RTX ablates the neurons. I don't know that. I'm not showing it. So we had to be a bit more sophisticated, and we knew what we had to do, which was to record the nerves, and that took us a while. But thanks to my current fellow, Liliana Tavares, we're getting this done. And what we are doing is we get microelectrodes to record the nerve activity during this whole same protocol. So this is the dog heart. This is the right ventricle. I'm lifting it up. This is the superior vena cava, the right atrial appendage. And between the superior vena cava and the right superior pulmonary vein, which would be here, this yellowish structure here is one of the ganglionated plexi. So this is where we have a ganglion of neurons, right? So we open it up and we put a couple of microelectrodes there. And we're also recording the vagal nerves in the dog. And then we go through the same protocol. So I'm going to show you one example. We've done 3 dogs with this. So this is how it looks at baseline. This is the ganglionated plexi, so the plexus of the right pulmonary veins, as I showed you. You see a P wave. Okay, so this signal here is the P wave. What you see in the background is either noise or nerve activity, and it's very hard to tell them apart. This is simultaneously the EKG, just to show that these deflections here correspond with the P wave, blood pressure, and then the right and left vagal nerves. So then we start apnea. And 2 minutes into apnea, saturation is still 97%, which is not far from the baseline. And we start seeing stuff. I don't know that this is noise or what it is, but it wasn't there before. Nothing in the vagal nerves. 3 minutes, more of that stuff, and we see, I don't know if there's anything here. Maybe yes, maybe no. Just looking at the data, right? Then more of these, and this, okay, this becomes a little bit more convincing. Like I could put an arrow here and make this more apparent. 3.5 minutes, I get more of these. 4 minutes, more of these. Less of the previous ones here. This goes back to kind of a baseline-like recording. But the vagus gets really angry, and now you can see there's something here that I wouldn't be able to, I wouldn't call it unless I had the corresponding vagal recording of the other side. It just tells you how delicate these recordings are. I mean, these are millivolts, and you have to have a complex set of hardware to really amplify this properly. But we keep going. We get up to 81% saturation, and at 80 by protocol, so that the veterinarians would not kill us, we start breathing again. So at 80 this is when we start breathing, and we get one more release of vagus, and then go back to normal. So okay, we thought, okay, good, that's cute. We have some. The first thing we noticed was some GP firings, and then the vagal firings followed. But then we looked a little bit more at the data. I said, okay, let's look at what the heart rate does. And thankfully, this software allows us to process the EKG and display the heart rate of every beat. And then we'll go back to the same recordings that I just showed you, and we start seeing, this heart rate goes up and down, up and down. I said, this is not random. This is something. There's something going on. And as this is at the very beginning, and then when the vagal discharges, so I was just showing you the same thing that I showed you earlier. You see these oscillations that go up and down that kind of correlate with vagal discharges. And most interestingly, when I start breathing, there's no oscillations. So if you plot everything, so here's the hemodynamic changes during apnea. In blue is the heart rate. Apnea starts here. The heart rate goes down. This is the blood pressure in whatever this color is, red. And you see how into the apnea you're still getting these oscillations that they seem to be getting more frequent, and that match the vagal discharges. Once you start breathing, the heart rate picks up, and you don't get those oscillations. And you see that here the blood pressure normally drops during apnea. And when you start breathing, and at the end of apnea, when you start getting into respiratory arrest, this is 6 minutes into it, you get hypertension. Okay, so we have a baseline set of data that includes the hemodynamic response to apnea, the heart rate, the blood pressure, and the vagal, and the nerve discharges from the heart. What happens when we give the RTX? So this time, instead of injecting the RTX in the pericardium, that almost killed 3 dogs with the VF and the ST segment elevation, what we did is we grabbed a syringe and a needle and injected the RTX inside the ganglion. So in that yellow piece that I showed you, we grab a needle, a small needle, and inject it there. Nothing happened for a while. So 1 minute, this is the recording. And unimpressive, the vagus is quiet, both vaga are quiet, and so is the GP. 10 minutes later, maybe something there, I don't know. 16 minutes later, I don't know if you can see it, but the blood pressure now is 160 with the baseline was 105. 20 minutes later, the blood pressure systolic is 240. And 30 minutes later, it drops back, and you don't see the background as active as it was before. Now we induce apnea. And this is what happens during apnea. Blood pressure drops, and it drops, and it drops. The heart rate kind of drops a little bit, and then it goes up. But there's no oscillations, none of this funky, coordinated stuff of releases of the vagus, heart rate oscillations. And so I think we have the logical sequence that I wanted to put together with the first data set was the first thing that happens during apnea, the sensory neurons get active and fire and tell, hey, there's stuff going on here. The blood is not coming as nice as we want it. That in turn activates superior centers that also leads to a vagal responses. And I think at some point there's there may be negative feedback between one and the other, because it looks, and I don't know that I can make this case, but in this situation where you start getting the vagal discharges, these are kind of alternating. So either you get one or the other. It's as if they were fighting each other. And that would make sense to justify these oscillations. Like they're up and down the heart rate. One releases, accelerates the heart rate, then the other fires and decelerates. And that interplay is what leads to this oscillation. The bottom line is you kill that, you kill the sensory neurons, and you eliminate that kind of dance of heart rate acceleration, deceleration, and vagal discharges. And instead, you get just a steady drop of blood pressure, and the heart rate starts going up once you get into, this is 10 minutes. This is a cardiac arrest, not really apnea. We also took the GPs, and with the help of Dr. Markovits, one of the pathologists in the RI, we stained the GPs with TRPV antibody, and just to show that indeed they are there, that it makes sense that if this compound is specific for TRPV1, that we are working on these cells that stain positive for TRPV1. So to conclude, we basically say that the RTX appears to induce an acute sympathetic afferent stimulation followed by recovery. That's based on the increasing blood pressure that we get when we inject this drug, and that goes away. And also that RTX abolishes the electrophysiological and now systemic hemodynamic response to apnea. So we can make this story that the sensory neurons get activated first when you get apnea, and they trigger a cascade of autonomic responses that culminate in the susceptibility for atrial fibrillation. So we hope we've done 3 dogs with this protocol, the invasive, the open chest with the neuronal recordings, and we are doing 3 more. We hope that we put together data set with nerve recordings, histology showing that these neurons are there, and we can revisit submitting the manuscript. I think we have a kind of nice story to tell. There is a clinical correlate, so this does not come out of nowhere, and it's very controversial in the clinic. But there's some groups that claim that when you ablate the ganglia of the left atrium, in addition to the ablation of the pulmonary veins, you get better results. Very controversial. Some people have published that PVI isolation plus GP ablation is better than PVI isolation alone. The problem is when you do, all we can do is burn. So when you say, I'm doing a PVI plus GP, you're just burning more. And sometimes you can find the GPs because when you start ablating, the patient goes bradycardic. And if you keep ablating, that response goes away, consistent with burning those nerves. But in these papers, they didn't even try to do that. They just ablated in the known locations of the GP. And in general, most people would agree that if you ablate more, you get better results for persistent AFib. It's also controversial in that when tested in the setting of surgical ablation, so surgical pulmonary vein isolation alone is not any worse than doing surgical pulmonary vein isolation plus surgical GP ablation. So it's controversial that it will have a therapeutic relevance, but at least mechanistically, what we wanted to show is that in the context of apnea, the sensory neurons may play a role, and the story with the RTX makes sense. So in the clinic, the vein of Marshall, as you probably heard me talk about many times, is part of the intrinsic cardiac nerves. So we know whether it is because it's a residue of this left superior vena cava, and when you're an embryo, the nerves that end up controlling the sinus node, if you were to develop a dextrocardia, would be in the left superior vena cava, which is the vein of Marshall after it becomes atretic. So it makes sense that embryologically, before the left-right differentiation, the vein of Marshall is just as loaded with nerves as the superior vena cava RA junction is. And we know that the veno-marshal and adjacent tissues have a lot of sympathetic innervation when stained with tyrosine hydroxylase. And when stained with, this is a macroscopic stain with acetylcholinesterase. So for parasympathetic nerves, you see even a little neuron here coating the pulmonary veins. And this area here, this is the ventrolateral nerve that innervates the posterior left ventricle, inferior left ventricle on the right, and some of the, sorry, this is right, this is the left, is next to the veno-marshal. So in the clinic, the veno-marshal was now 16 years ago, 17 years ago, shown to be a site for initiation of AFib in certain patients with paroxysmal AFib. It was shown to have a lot of innervations, and since 2007, we've been working on the idea of putting a catheter in there and using it to deliver alcohol, which is about the crudest thing and the kind of embarrassingly simplistic thing to do, to give alcohol to ablate, but that's what had clinical use. And with this technique, we showed that we could ablate tissue giving alcohol. This is again in a dog. But not only we could ablate tissue, if we stimulate the vagus nerve before and after, we ablate the vagal response. So we are killing nerves in doing this. And we showed that by measuring refractory period. We abolished the drop in ERP caused by vagal stimulation when we gave alcohol. This is the location of it. So we took it to humans. You're familiar with this. And right now, we've done a lot of studies. What the bottom line is that whether we're killing nerves or we're just killing tissue, you create a scar in this area in humans that may help for certain problems, for certain clinical problems. The chief of them is perimitral reentry. When you have electricity spinning around the mitral annulus like this, it can be really hard to ablate. And with alcohol injection in there, you can get very, very quick block of conduction in that area. It takes some time. I'm going to skip through this. What I wanted to show is the data supporting the idea that the veno-marshal is not just part of the intracardiac nerves, but it's a vascular structure that is it's a vascular route to the intracardiac nerves. And we can use it for ablation, but we could also use it to modulate those intracardiac nerves. And the data is, we published this in JACC a couple of years ago. What we did here is we put a micro electrode catheter in the veno-marshal. I don't know if you can see it. There's 4 poles here. Is a 1.7 French quadripolar catheter, no longer manufactured. We put a catheter like this there. And then we gave high-frequency stimulation. So we injected current there. But we wanted to inject it in a way that would not stimulate the myocardium. So the way we did is we gave these short pulses of 100 milliseconds, synchronized to the P wave. So because they were synchronized to the P wave, the atrium was refractory. So we give this stimuli in the veno-marshal during atrial refractoriness so that we don't capture the myocardium of the atrium. So what are we doing then? Well, we did this. It was kind of very, very complex to set up because we needed 2 sets of stimulators and it was a pain. We did it in 8 patients, and in 4 of them, we induced AFib, but pay attention how we induced it. This is the burst of high-frequency stimulation. Because it is during atrial refractoriness, we did not stimulate the heart. You see, this goes back to normal. You get a sinus P wave and a QRS, and then AFib starts. So you can't say that this directly stimulated the myocardium, but the very first beat of AFib started from the veno-marshal. So the idea here is we're stimulating some nerves that can trigger AFib. We gave alcohol and we repeat the same protocol and we don't induce it anymore. This was because this was painful to set up. We did a more crude approach, which is just put the microelectrode catheter in the veno-marshal and then do high-frequency stimulation. And when we induced, in the vast majority of the patients, was this pronounced vagal response. So this patient was in sinus rhythm, sinus here, then we do the high-frequency stimulation in the veno-marshal. Not only we induce atrial fibrillation, but also the patient goes asystolic for almost 6 seconds. And this to me is fascinating because the veno-marshal is all the way here in the lateral wall of the left atrium. The AV node is in the septum, So somehow we are stimulating. How can we justify AV nodal block? By stimulating the lateral wall of the left atrium. We have to be stimulating neurons that connect through interneurons with the plexus that controls the AV node to stimulate that and induce a vagal response, a parasympathetic response. So again, this was in patients. We induced this vagal response and atrial fibrillation. After alcohol, we got rid of both things. Now, you could say, well, you don't induce AFib because the myocytes are dead by alcohol. Sure. But the AFib that we induce also without capturing the myocardium was no longer inducible by that mechanism. So we had a similar response, less of a response in patients that had previous ablations. So patients that had previous ablations, only 75% had some kind of parasympathetic response. Whereas in de novo, all of them had either RR prolongation or a systole induced by high-frequency stimulation. So anyway, this is kind of the background that supports the clinical trial that we have now. Veno-Marshall alcohol combined with regular ablation in patients with persistent AFib. We have 8 centers, soon to be 9, and we have 2 studies. One is for patients that have had a previous ablation failure. It's called MARS. And patients that are undergoing the first ablation, which is called Venus. MARS, we finished enrollment a few months ago. And Venus, we are up to 212 patients now in the 8 centers that are enrolling. And we have 120 to go. And we have until July 2018 to finish the study. Probably we need to apply for a no-cost extension for the follow-up. But I think we'll get this done. What I also wanted to discuss is planned ancillary studies that I've been thinking for the past couple of years, and I haven't finalized yet. But very simple. I wanted to use the opportunity that we have the structure of a clinical trial with all the data collection arrangements, the electronic, web-based patient files, and all the detail that we collect of those 405 patients in total, to add some ancillary studies that could help us learn more about AFib. I don't kid myself thinking that Veno-Marshall alcohol is going to revolutionize the treatment of persistent AFib. If anything, we may get some marginally better results, perhaps for patients that have perimitral flutter. But this is not so much a trial that will change the management of AFib, but it's a very good opportunity to learn about AFib management. And with these mechanistic studies that I'm proposing, hoping to propose, we can achieve that. So basically, I divided these ancillary studies in 2 aims. One is to delineate the structural determinants that determine the outcomes of ablation, of catheter ablation. And that's aim 1. And aim 2 is to delineate the functional determinants. So when you're dealing with persistent AFib, most of the time, it's not a normal heart. Most of the time, persistent AFib patients they may not be overt cardiomyopathies, but they are in their 60s with several years or decades of high blood pressure, with sleep apnea, some diabetes. Most of them are taking medications for high blood pressure too. So there's some structural involvement or some structural correlate of the AFib. Most of them will have left atrial enlargement, almost always, and almost always have increased left atrial pressure. So we wanted to characterize the structural changes that are associated with AFib, not only at baseline, but also the response to ablation, to those structural changes, and how that remodeling correlates with ablation success. So we wanted to do 2 things. One, atrial innervation, which is a bit of a very ambitious goal. And the other, which is more established and less controversial, is looking at left atrial scar and remodeling with MRI. So the innervation is interesting. So MIBG is a compound, meta-iodobenzylguanidine, is a metabolite in the synthesis of noradrenaline, And there is an isotope that can be put into it and becomes a nuclear tracer. And it's been used to look at sympathetic innervation in heart failure for quite a number of years. It's never made it as a routinely used tool, but MIBG scans can be used to quantify the sympathetic innervation of the heart. And that has prognostic implications for heart failure. There's a company in Israel that created not only MIBG SPECT hardware to look at the atrial innervation content. And the idea here is wherever you have catecholamine synthesis, most likely you have, because the parasympathetic and sympathetic nerves go hand in hand at the organ level. So most likely you will have also parasympathetic nerves. So the idea is you could map cardiac innervation in the left atrium. I've only found one paper, and this is pretty much one case, where they looked at the SPECT data. They were able to do a 3D reconstruction of the SPECT data in the left atrium, which is quite a lot to say, because you don't get a lot of counts in those MIBG scans from the left atrium. Most of it comes from the left ventricle. And they did a 3D reconstruction, and they correlated the hot spots in the left atrium before ablation with a change after ablation. So they showed how ablation can actually eliminate these nerves. So what I'm doing here is I'm trying to get John Memarian to, we have the MIBG, we've done MIBG SPECTs. I need one or two examples where we could defend the idea that we can see MIBG counts in the left atrium and then quantify those before and after. Because if we say, okay, patients that have a high innervation count or low innervation count going to ablation are less likely to improve, we have something to be learned. Or patients that respond to Bain-Marshall, maybe because we denervate those patients better. We've shown that we denervate those patients in functional studies, but it would be nice to do it anatomically. The second aspect of the structural aim is with MRI, and this is in collaboration with Deepan Shah. The idea here is to do an MRI before and after ablation, look at the structural determinants of success and whether it is the baseline structural changes or the remodeling after ablation. And this paper I came across a couple of days ago, where they actually looked at, and Deepan, correct me if I'm wrong, but this is a delayed enhancement, it's gadolinium delayed enhancement MRI, but somehow they were able to do a 3D reconstruction of the fibrotic areas. They were focusing on the SVC-RA junction to look at the sinus node, but they're imaging fibrosis, which is interesting. Is one thing that I would want to do in this project. Again, the idea is get more detailed anatomical and structural data about ablation candidates before and after and correlate that with outcomes. It's important not just for that, but it's related to the second aim. The second aim is a functional one, and I need to discuss a little bit about rotors in AFib. So I showed you the rotor with electricity spinning in some models of atrial fibrillation. So a few years ago, one of our colleagues in San Diego, now in Stanford, who actually was here giving grand rounds, came up with a way to process atrial electrograms during AFib that allowed him to reconstruct the global propagation patterns. And he used these two large basket catheters, 64 electrodes in each. He had one basket in the right atrium, one basket in the left atrium. This is kind of the signal that we all see, and then he gets 64 times 2 signals, and he's able to process the data in a way that it shows, according to him and in his patients, rotational activity that is stable. And not only that, he claimed that if he ablates guided by this map, he doubles the success of ablation. So this kind of shook the field 4 years ago, and he rushed to coming up with a company to commercialize this. Was lucky enough that EP is a very profitable business and there's a lot of industry, and was incredibly lucky that Abbott wanted a piece of that business, and just to get in, bought his company for $300 million. Wow. So now, If you ask a lot of people, they will tell you it is bullshit. Sorry. So, but he sold it. Now Abbott bought St. Jude, and now St. Jude and St. Jude has a mapping system, and they're trying to develop it. Since then, so he published 2 papers claiming incredible success. And then one paper came out, it's interesting, from UCLA. My former chief was an author in the first papers showing that it was great, and then was the lead author in the first paper showing that it was not great. And it just tells you, to be successful in academia, you just have to know what the, yeah. You just need to know what the field is primed for and deliver. Anyway, so basically, other papers shown that, well, they couldn't find any rotors, and when they ablated what they thought was rotors, they got success in 1 out of 24, maybe, or AFib organization in 3 out of 24. We couldn't see any rotors. 7 more groups, as I was writing this, 7 more groups have reported over the past 8 months failures of this approach. But the money's in the bank already. So we looked at this, and we had several problems. We had problems with the idea that a stable rotor underlies of all atrial fibrillations. That's what this guy claimed. And that's key for this technique to work. So he claims a rotor is there all the time. You just don't see it because there's noise in the electrograms, but when you see it, it's there. And if you ablate, it terminates AFib. So we had issues with the mechanistic paradigm, that we don't buy that there's a single rotor all the time. We had issues with the ability of these baskets to have enough resolution. I mean, you can have the splines 1 inch apart. How can you resolve a rotational activation that may take 1 centimeter square? So we had issues with the mechanistic paradigm. We had issues with the technical aspects of the feasibility of recording with enough spatial resolution. And of course, we had issues with the outcomes. Very respected mechanistic people, arguably the leader in AFib mechanism research, Khalife from Michigan, with papers in Nature talking about spiral waves and all these things, totally bought into it because it's his paradigm, the mother rotor. And when I talked to him, I told him, but you know, it's bullshit. And he says, but look at the outcomes. And I said, you know, don't you know science? Don't you know clinical science? I mean, you criticize, he's a very harsh critic of scientific papers. The clinical papers are even more prone to BS. The bottom line is we got together with Amish, who just stepped out, who is a phenomenal software engineer and major in mathematics. He knows more mathematics than I ever knew existed. And I had done some mapping of AFib in my early days at UCLA with optical mapping, and I was familiar with the analysis that was based, that this was based on, which is called phase mapping. And you know, in conversation we started talking, and we said, okay, if there's a rotor spinning around and it's fixed, the time it takes for it to make one turn is relatively fixed, because that's determined by conduction velocity and refractoriness. That's not going to change. So rotors come, if there's a rotor here that spins 3 times, it will have a signature frequency, because the time it takes to rotate is fixed. So the period is fixed. So 1 rotor, 1 frequency. If you have a rotor going around the tricuspid, the cable tricuspid isthmus, it takes 200 milliseconds to do that. It's always going to take 200 milliseconds. So its signature frequency would be 5 hertz. So we said, okay, what if there are rotors that come and go, but when they are here, when they are rotating, they have a signature frequency. So we can then reconstruct the phase of neighboring areas for each frequency. It's a complex thing that I don't have the mathematics to explain. The bottom line is that we came up with a rotor mapping algorithm, and we tested it in all data that I had from UCLA of fibrillating monolayers. So a 2D cardiac tissue, 2-dimensional cardiac tissue made of culture cells that went into fibrillation. Amish put his algorithm, and it worked. It picked up where the rotors were. So if we filed a patent we renewed it a few months ago. That's supposed to identify rotors, and we're not married to the idea of a single rotor being there all the time. And what we wanted to do is take this opportunity that we're going to be mapping AFib to use this proprietary rotor algorithm in this project as a way to say, okay, when you ablate in areas that have rotors, then you're going to have success. And therefore, what we should do is, by our technology, to guide ablation. Whether we buy it or not, the idea is we need to understand each AFib so that each patient gets the ablation they need, guided by this functional mapping. We also thought that it would make a lot of sense to use this Vein of Marshall project for a very cute physiological experiment in humans. The idea is, okay, we can put a balloon in the vein of Marshall that is draining venous return from a piece of left atrial tissue, right? We do that before giving alcohol. Well, what if we give a drug that could manipulate or could change the electrophysiological properties of those areas? The theory says that rotors will form in areas that have the shortest refractory period. Wouldn't it be cute? I mean, this is an experiment. You cannot do it in animals, but you can in humans, which is, let's give adenosine in the vein of Marshall. Adenosine is safe. We give it all the time. We give it as part of the procedure to test a technical aspect of the ablation. So what I want is to give adenosine in the vein of Marshall so that the regions around the vein of Marshall will get an artificially shortened action potential duration. And if that's the case, then a rotor should form. At least that the theory should predict. And that's what we wanted to do. So we are proposing, as part of this functional exploration of AFib, to test the validity of the mother rotor hypothesis by mapping the rotors at baseline using the commercial algorithm plus Amish's own, and then give adenosine in the vein of Marshall to regionally change the electrophysiological properties of a piece of tissue only, and see how do the propagation patterns change. And if the motor is true, then we should see a rotor in that area. The third aspect of the functional exploration is this lady, Natalia Trajanova. She's a big, very famous person in computer simulations in cardiology and electrophysiology. And she's done a project where she takes, this is an MRI of a patient, a dead patient, there's a cadaver, where they did diffusion tensor MRI and they can reconstruct the fiber orientation. And in 3D. And it's cute because you see this crisscrossing of fibers right here. And do you know what's in here? The vein of Marshall. The vein of Marshall is right there. So, and this is very dear to me. When I was a fellow, one of my first paper was about crisscrossing of fibers and reentry in fibrillation. So when I saw this figure, I thought, you don't know what you have in your hands. This is beautiful for me. So what she's doing is she takes the MRIs, she takes computer models of action potentials. So she has a three-dimensional construct in a computer where there are millions of cells with all the ion channels that we know and reproducing all the symphony of ion channels opening and closing to create an action potential, and the cells are coupled, and she can map a propagation. Now, one beat takes 1 week of computation. She can change the shape of the model depending on the shape of the patient's atrium. So she does patient-based computer simulations. And she can introduce different fiber orientation changes and sizes and so forth. What I wanted in collaboration with her is we take our patients, we get the MRIs and the fibrosis, we measure a crude estimate of action potential duration or refractoriness with catheters in the procedure. So we give her a regional map of action potential alterations. We then give her the response to adenosine in the vein of Marshall. What I want is for her to do computer simulations and then come back and say, okay, this patient, when we induce a fib, the rotor tends to happen in this location because of the fibers, because of the fibers you gave me, the action potential alteration you gave me, and the structure you gave me. This patient is where this is where the AFib is coming from. And each patient has its own simulation, and we can go back and then, okay, we're going to have to ablate in this spot because simulations say this is where this patient's AFib is coming from. So that's, I finished writing the specific aims page last night, and then I put it together here. But my hope is that if I combine some of the preliminary data we have from the clinical trial, if I get a couple of recordings of adenosine in the vein of Marshall showing shortening of the action potential in that area, if I get John Memerian to give me one MIBG scan where we can claim there's something in the atrium, and Deepan to give me some cute MRI scan like this, and Natalia to give me a letter of collaboration, then we could have a viable grant. But that's where we are. So I'll stop there. Any questions?
I thought that was great. I mean, you put together biology and EP and cardiac structure. It was really quite an amazing talk. Did you say that it's nerve endings with the vein of Marshall injections? Is that what you think is having the benefit of knocking out those sympathetic nerve terminals?
So what we know is we kill the parasympathetic because it's when we stimulate inside the vein of Marshall, we induce a parasympathetic response. We get asystole. When we give alcohol, we kill that. Now, the vast majority of the nerves there are cholinergic, are parasympathetic, but they are sympathetic too. That's the sympathetic are the ones that we map with the MIBG.
Yeah.
We don't have a tracer that I'm aware of that can track parasympathetic nerves. There's some PET tracers, but we're not there yet. But to your point, one of the bases of this project is that vein of Marshall has unique therapeutic mechanisms. We're not just destroying tissue, but because of the way we access it and the structures next to the vein of Marshall, we're actually doing neuronal ablation as well.
The other point I have is a vascular point, and that is that TRPV1 channels and other TRP channels are present on the vasculature, and that increase in blood pressure you saw, I just wonder if there might have been some systemic leakage of your toxin that was having a vascular effect.
It is possible. That's one of the things we thought we would ablate by direct injection in the GP. We would eliminate. So when we put it in the pericardium, we know some of it is going to circulate, especially in the closed pericardium. But with direct injection, I don't know.
It still caused hypertension, right? Even with direct injection,
it took longer.
Like a cardiac,
it took longer.
It's almost like a cardiac vascular reflex, because you can't expect such a high blood pressure change just by changing output and contractility.
No. I think that you would get if you stimulate the stellate ganglion. You get that kind of response. So it's interesting. The way I interpreted the response to the racemic ferrotoxin was we're hijacking the autonomic response to pain in a dog that doesn't experience pain, because like I said, you can cut the chest open and blood pressure doesn't change. The dog is not experiencing pain superior conscious pain, obviously, but the autonomic response is activated directly by this drug, and it goes away. It goes away. I don't know if what we see is due to leakage into the circulation. It is possible. I don't know. I mean, we could do a study of a couple of dogs where we just give it IV and see if the same thing happens.
Because I think what's fascinating is I don't think we know exactly how sleep apnea worsens hypertension, because people with sleep apnea have high blood pressure.
Yeah.
Even diabetes on the metabolic realm, and I've had patients, and I wrote a case report in residency, a guy who we did a tracheostomy for bad sleep apnea, and then within 24 hours, insulin requirements, blood pressure, everything comes down. So that's why it's fascinating that there's some hypoxic response from the heart and the nerves, and then
Yeah.
it's almost like does your vein of, in these patients, I don't know how many have sleep apnea and how
Yeah,
many of their blood pressure
We'll have to look
gets
at that.
better, just not just AFib.
It makes sense.
So, from all this new data that you're learning, do we now know, or do we have a mechanistic idea of why left atrial enlargement causes atrial fibrillation?
Yeah, I mean, there are correlates. So left atrial enlargement happens because you have increased left atrial pressure. And we know that increasing the left atrial pressure almost immediately shortens the action potential duration. It may be mediated by the same neurons, but in experimental models, just clearing the mitral valve, immediately the left atrial pressure goes up, and the refractory period shortens, and it's easier to induce AFib. So that's almost immediate. So pressure is one, and the other is fibrosis. Once you get fibrosis, the propagation, electrical propagation becomes more scalloped, more local conduction blocks, re-entry around clusters of fibrosis.
But then when you do ablation, you want to produce more fibrosis.
Yeah, but it's
So
to
how
break
does
that.
that sound?
because you go from clusters of patches of fibrosis here and there to
To a big sky.
restricting the areas that are. If you don't get electricity around fibrosis, you don't get electricity at all in a whole patch of tissue. Who cares about? You
Right.
can't re-entry. You can't create re-entry around any patches. It's all destroyed.
Yeah.
So, Miguel, it's if you don't do electrophysiology to understand all these circuits may not be easy. But maybe a simple-minded approach also to the difference of potential mechanisms along the path of fibrosis. There's a recent paper, and I within the last couple of months, looking at ATTR wild type and specific deposits in the atrium. And if you look at the frequency of ATTR for amyloid, right? For those that don't follow that literature, but it occurred to me reading that paper and then listening to the part of the lecture that I came over is that there's probably a greater number of people that have structural abnormalities in the tissue that are not clearly defined, that may have potential interactions in the type of conduction, the speed, or factors that are clearly not known today. But has anybody looked at the ultrastructural level atrial fibrillation versus atrium of those individuals that have no AFib? Because I think not every big atrium has atrial fibrillation. So I would argue that it's probably not just the size, but the size and deposit of other molecules and the change path, the change. Anyway.
There is when I was in the study section in the United States, I reviewed a grant. One investigator from Arizona came up with this idea that AFib was dementia of the left atrium. And she showed deposits of amyloid peptides. I don't remember the detail, but it was the combination of oxidative stress and some peptides that got deposited there. And she showed deposit of amyloid material in AFib, and she was studying if the electrophysiological effects of those, and indeed she showed shortening of the action potential. So there may be a profibrillatory action of amyloid deposits in the left atrium, and if that mutation is associated with AFib, it makes all sense.
I mean, it's interesting because you talked about imaging. I don't know if you can agree. And supposedly there's some imaging modality to detect
So we have
TTR, right? So-
right now we have the TTR nuclear study, which picks up just the TTR deposit. So technically,
So-
we use that for TTR amyloid right now.
And so,
It's a spec. You
Pyrophosphate.
can do a 3D spec or
yeah, I can pronounce it better.
Pyrophosphate.
But
see if there's anything in the atrium.
so it'd be of interest if you're going to do imaging. You specifically looked at. I think people underdiagnose. I mean, amyloid years ago, nobody really would diagnose it correctly.
Yeah.
And the senile or the ATTR wild type, which is now what they refer to, it's probably way
I
underdiagnosed.
think that's a fantastic idea, and I think it would make so much sense to throw another
Simple
scan
imaging.
to this, and if we have a scan that can pick it out, the key is whether we can have enough counts in the atrium. Because most of these scans are dominated by the left ventricle, and I don't
So
know. if-
more importantly for us that are not electricians, that you may be able to modify pharmacologically that. Right, so.
Is there anything?
Yeah. There is drugs that are being tested now for
For amyloid.
amyloid, and yes, I mean,
No, I think the
plenty.
amyloid hypothesis is very fascinating because even the amyloid that we see, right, we call it senile amyloid. Everybody has the TTR protein. We don't find the mutation in everybody, but there are some old people who get it deposited in the heart versus some who don't. So there is a lot more interactions which we don't understand why amyloid, gets deposited in an organ. And I think the hypothesis, it makes sense because we don't know so much. And it might be an easy thing to do if there is already data suggesting there could be amyloid deposition.
Yeah.
Patients who don't have any LV pathology.
And it may be more, but see, like Dr. Q said, it's not only the size. I mean, clearly there is a relationship, but there are big atrium with normal sinus rhythm, and others that have atrial fibrillation.
Actually, in the AFib of the old people,
Atrium is small
the atrium enlarges after the AFib.
after the AFib.
Because we've had a lot of these people that have had echoes before, when they're in sinus, they were fine. Then they go into the thing, then of course, then you get the secondary. So this is very interesting.
So
hypothesis.
But
I mean,
when you do the MRIs for the amyloid patients, it's not, you can't see that in the atrium, though, right? The gadolinium
We see hypertension
in the atrium.
Yeah.
So technically, you could use the MRI to, if you're gonna use MRI in here, you could use the MRI to look at the enhancement, but it's non.
But MRI is, yeah.
Specific for,
It's gonna be non-specific.
No.
A lot of atriums have scar too, can you distinguish?
Yeah,
audio?
no, you can't, you can't.
That would be something.
Anything that causes expansion of axillary space,
Yeah.
so both amyloid or fibrosis, yeah, that could be.
one thing,
Anyway.
if we get this paper published on the robotic biopsies, we could throw in
Atrial biopsy?
patients and getting biopsy. So with
Of the atrium?
the robot, I did
Done it in the.
4 years ago,
Yeah, but in the atrium,
6 pigs in the septum.
the ventricle you can, but I think in the atrium maybe.
No, with intracardiac echo, and if you use a Hansen, a robot, to guide your biopsy to the septum.
No, that you could do, but I think that if you have imaging for amyloid, I think that would be
Okay.
not too much to add to your protocol, and I think it'd be good. I mean, I think it's
All the
under.
AFib ablations you're doing.
See, the problem with this spectrum.
Take a bite.
Pyrophosphate is, I don't think you're gonna get enough counts in the left atrium.
Yeah, I think the
Yeah,
atrial.
It's a very thin wall structure, that's a problem.
What about PET?
I don't know, is there a pyrophosphate count?
I don't know. I'm just asking because we-
No, but,
we may have
so-
PET in another year.
So the problem with
I mean, I didn't know you were gonna do this today, but there's this recent paper, so the natural history of senile or ATTR wild type amyloid from the Mayo Clinic. I can't remember where it came out, but I'm sure Google will give you the reference correctly and more accurate than my comments, but I think that there is probably something here that may be worth pursuing.
I toyed with the idea of adding biopsies, and it gets complicated because then you have to convince a reviewer that we can safely get biopsies. And if we get this paper, so Arvin and I have a paper, and Barry, where I took 6 pigs and biopsied the intratracheal septum, and in one pig I took 16 biopsies to prove that it would not kill it, would not perfect.
Intra-atrial septum.
Intratracheal septum. So
Okay, well, the worst thing you can do,
So you go from here.
or you can do you'll do an ASD.
Yeah.
As long as you don't biopsy to
It's
the back.
smaller than doing a transeptal puncture. We go 14 French across the septum
Yeah.
for a watchman, and it closes.
And
But I
something-
did not
some-
have a clear idea as to what to test, but the amyloid hypothesis makes a lot of sense, especially for persistent AFib, where. the
And
problem is-
and I think it's grossly underdiagnosed. I think you read that paper, and I think that, maybe the techniques to diagnose, people don't even think of it.
Yeah.
you know,
won't
but,
pick it up on H&E.
anyway, but,
Right, so
No, no,
you
no.
have to do the special staining.
yeah, correct.
If you have, those pigs were not AFib pigs though, right?
No, no.
Normal pigs.
We're normal.
Well, I mean, take our hearts and then look at just plain atrial histology of AFib versus
Yes, so
non-AFib.
our
We could do
expanded
that.
hearts, we've talked about
So
it.
we actually could do that.
I don't think we save the atria, but that is something that we can add on to the protocol.
There may be a piece of it,
Yeah, we can start doing that, and I'm sure you'll have enough patients.
that may not be a bad idea.
Yeah, you
That we
get-
can
if you guys have
prospectively
a
start
bank of-
collecting the atria.
And you know if the patient had AFib or not.
Yeah, we can easily do it. That's a good idea.
Yeah.
Good.
Very good. Darwin, I need to walk over.
Did you get a,